you so much and welcome. Good evening, all. Welcome to another session from MedXM Expert. This is Dr. Moses, your mentor for today, and we are going to talk on the topics which you all had requested. That's what we are doing nowadays. Whatever topics you had requested, we are doing it. All right, now we have come to ALL, AML, CML, and CLL. One more request that has to be attended is one doctor asked that he had some, issues with understanding nematodes. Definitely, we are going to do nematodes and the life cycle, just a brief of it, and how the symptoms present, associated syndromes, and how do we treat nematodes. Now, the topic which we are going to see today is kind of, very dry topic. Many people get scared of the ALL, AML, CML, and CLL, including me, because I don't like much of hematology. But since the request has been made, I will try my very best to make sure that you understand the best things regarding this. All right. And without further delay, we will quickly go into the session. The very first thing, you need to know some basics. I know many of you are consultants. You don't need to know the basics. At the same time, I can also see some youngsters, some interns who are listening these sessions. So for you, we are going to brush up some basics. After the basics, we are going to quickly go in a session. It's just a 40-minute session, okay? First thing you need to know, this is something called common myeloid progenitor cell, all right? This divides into, first there will be hematopoietic stem cells, which divides into common myeloid progenitor cell and common lymphoid progenitor cell, okay? This hematopoietic stem cell typically produced in the bone marrow. Then it comes and it divides into two series. One is a myeloid cells and another one is a lymphoid cells. All right. This myeloid progenitor cells give rise to your RBCs, that are your erythrocytes, your platelets, your basophils, your eosinophils, neutrophils, and monocytes. All right. I believe all of you understand the basics. Next, what we are going to do, we are going to see is how a lymphoid progenitor cells divides into. They divide into your B lymphocytes, T lymphocytes, and as well as your NK cells. NK cells are nothing other than your natural killer cells. This is the very basic. Okay, this is the very basic. And these topics are important for all three parts of MRCP, part 1, part 2, and phases. Part 1, part 2, and phases. All the three people, you have to be very, very aware of it. All right, especially if you are going to give exams in India, especially in South Indian centers like Chennai, you are likely to get a cancer case very easily. And as well as in Kerala centers, they are, because these centers where it is located, they are oncology centers, this PACES center. So you will easily get this PACES cases, okay? You will easily get this as your PACES cases. Your CML has come and you have to identify all these things. So types of ALL. First, we are going to see about ALL. In this, I am going to teach you only the things which is relevant for you. I am not going to teach anything that is complex, which is not needed for you, okay? Types of ALL. There are 3 types specified by British Oncology Study Group. B-ALL, your T-ALL. When they occur together, it's called a mixed type ALL. Okay. Remember, B-ALL, T-ALL, and mixed type. Okay. B-ALL is the most common childhood leukemia. Just note down and understand the points which I am telling you. That's more than enough to get through your exams. Okay. B-ALL is the most common childhood leukemia. The symptoms you will find are anemia leading to weakness and fatigue, thrombocytopenia leading to petechiae, because thrombocytopenia, your platelet counts will go down and patients will easily bleed. Then neutropenia. What happens when the neutrophil counts go low? You will get infection. Then comes TAL. Okay, this is most commonly something this will present in the adulthood. Okay, adulthood. And there is a mixed type which is very, very, very rare. Very, very, very rare. Okay, first thing. Next thing, what is the etiology? The etiology which I am going to give you right now is the same for nearly all the four cancers we are going to see. Okay, it's the same for all the four. The very high risk for any condition, let it be cancer or rheumatological condition, the monozygotic twin, it's a very, very high risk. Then ALL is also associated with your trisomy 21, Klinefelter syndrome, and other conditions such as Fanconi syndrome, Bloom syndrome, ataxia telangiectasia. This has been asked as an MCQ twice, so you should be very, very careful and note down this point. Trisomy 21, Klinefelter syndrome, Fanconi, Bloom syndrome, ataxia telangiectasia. Also, you should know about these syndromes separately. The reason why is these 5 syndromes which I had underlined now is asked independently as an MCQ for part 1 and part 2. Cases people, you need not worry about that. Nobody's going to ask you about these things. Maybe Klinefelter, if you are getting a Marfanoid habitus patient, they may just little probe you on Klinefelter syndrome. Otherwise, you need not worry. But for part 1 and part 2, this is very, very important. Okay. Also, there is a growing evidence which suggests germline mutation that can predispose us to ALL. And obviously, environmental factors, radiation exposure, smoking, everything can cause. Then comes your viral infections and any history of malignancy and treatment with chemotherapeutic agents, poor maternal diet, all these things, and abnormal folate metabolism and any polymorphisms associated with that. All these things can predispose an individual towards an ALL. Next, the pathophysiology. In BCR ABL, cross-linking is the main pathophysiology of B-type AML. Just remember that. Okay? And BCR, B-cell receptor gene, is in chromosome number 22. ABL is in chromosome number 9. This is an MCQ point. Okay? And the fusion occurs. This is the main pathophysiology for BALL. Okay? Just note this down. That's more than enough. You don't need to know the complex percentage and everything. Where BCR is located, chromosome 22. Where ABL is located, chromosome 9. That's all you need to know. And the fusion. This is the main pathophysiology. Rest, nothing matters. Then the clinical findings. The clinical findings which I'm going to tell you now is the same for almost all the cancers. Of course, all the 4 hematological malignancy which we are going to see. But there are certain symptoms specific for that, which I will tell when we are seeing the respective malignancy. Pallor. Obviously, whenever there is an anemia, you will find a pallor. And ecchymosis can be there. Petechial hemorrhages can be there. This is very important for all the 3 parts, especially faces people also. Lymphadenopathy. You can easily find cervical lymphadenopathy. And if you note a cervical lymphadenopathy in a patient's examination, please ask to examine the axillary lymphadenopathy. If the examiner and examine. And then you can also find hepatosplenomegaly. Okay, hepatosplenomegaly also you can find fever, fatigue, dizziness, palpitation, dyspnea, all those things you can find. Then you can find bruising, you can find epistaxis, and you can find menorrhagia, all these things, all bleeding manifestations due to thrombocytopenia. Then you can find headache, papilloedema, nuchal rigidity, and meningitis. All these are CNS manifestations of hematological malignancies. Due to CNS infiltration, you will get a headache. You see a papilloedema, you can find if they complained of headache. There is one case, I think in Cochin Center or somewhere, I don't know. And another same case came in UK Center also. The complaint was headache and blurring of vision. When people just made up a mind, it could be some, some tumor or optic nerve pathology, but that's a CML infiltration into the CNS system. That was the diagnosis for that case. They kept in paces. Renal enlargements, bone pain, and painless unilateral testicular enlargement. This is another very specific thing you can find. Painless unilateral testicular enlargement. So all these findings can be. All right. Now comes to investigation. What are the investigations you will take and what exactly you will find there? This is very important for part 1 and especially for part 2 people. In any malignancy, you start with full blood count with differential. You'll find anemia, you'll find leukocytosis, obviously you will find neutropenia. And peripheral blood smear. In peripheral blood smear, if you take, you'll find leukemic lymphoblast. I'll show everything in picture, you will understand. Then serum electrolytes, typically serum potassium, phosphorus may be elevated, and serum calcium may also be elevated or sometimes decreased. Serum uric acid and LDH will be elevated invariably. Okay. Then bone marrow evaluation. If you see the bone marrow evaluation, you can find hypercellularity, you can find infiltration, and you can find leukemic lymphoblast in the bone marrow. See this? These are the lymphoblast cells in Gimsa right or right Gimsa strain, however you want to call it. These are your leukemic lymphoblast. Part 2 people, please be certain. Just give me a minute. Yes. So these kind of slides you can expect in part 2 examination. I think now everything is computerized, so the images may be better. Previously, they were giving it in a paper, and the print will be very pathetic to watch. Okay, it's a soreness to the eyes. I think now these pictures should be better. The picture should be better. Now comes to acute lymphoblastic leukemia, lymphoblasts. These are the lymphoblasts you can find, and you can also see a condensed nuclear chromatin. See this picture if you see carefully. Condensed nuclear. Somebody's microphone is on. Please, if you don't mind, moderators, please look up. It will be very disturbing for me to. It will be very disturbing for me. Okay, then small nucleoli and scant agranular cytoplasm. All these things you can find. See multiple slides. That's what I would advise for part 2 people. See multiple slides again and again, over and over. Then only you will get it. All right. Questions are very ambiguous. Then you will do immunophenotyping. You should know the markers. 19, 22, 79A in BALL, and 3 and 7 in TALL. These two should be known by you by heart. Okay. Someone wants the clinical picture slides again. No problem. These are the clinical features, doctor. You'll get pallor, ecchymosis, petechia, lymphadenopathy, hepatosplenomegaly, fever, fatigue, and very importantly, bruising, bleeding in any form, through the eyes, through the nose, through the mouth, through the back passage, menorrhagia, anything can occur, and renal enlargement, bone pain, and specifically unilateral testicular enlargement. Okay, and CNS findings can be anything that will mostly mimic a meningitis or an encephalitis in leukemic infiltration. Right? Hope you got it now. Then immunophenotyping, you should know the CD markers. 19 and 22 and 79 for B and 3 and 7 for T. This has been asked in MCQs multiple times in part 1. Please write it down and please do study about this. Okay? Please do study about this. And scrotal ultrasound you have to take, because I told you there will be unilateral scrotal enlargement will be there. And for any CNS, you know the complaint. What you will do for a suspected meningitis? You do LP, you will do CT brain, you will do MRI, you will do fundoscopy on the bedside. Paces people, if you get such case, any visual disturbance, please offer, I will do fundoscopy. And if you're going for a paces examination, please take your fundoscope. Please don't use any fundoscope there. It may be good also, but if it's something you don't know about how to turn it on and how to adjust the setting, you will waste your minutes. Wasting minutes is wasting time, wasting your money, wasting your examination, and wasting your life itself. So don't waste any second. Then PET scan, then fish. I'll tell you what exactly we'll look at that. Then you need to do baseline cardiac functions and Muga scan especially. This is a specific test before starting anthracyclines, because all the anthracyclines has the propensity to cause cardiomyopathy. They had asked in a recent exam, both part 1 and part 2 in the last 2 years, what is the most specific test? In that, they asked the most specific, it's not even echo, it's Muga scan. It's Muga scan. Okay. Next. This is a flow cytometry result in a typical BALL. Okay. This is a BALL. You know what are the markers of BALL? CD19 and 22. Okay. This image hasn't come for part 2 yet, but they may ask you. So part 2 people know this. Part 1 people now itself get used to this. In no time, you can master part 2. Okay. Now treatment. The treatment is algorithmic. It goes in phases. Okay. You don't need to know all this list, but just listen to me and note down what is needed and what is essential. This is the updated treatment protocol. The first phase of the treatment is going to be an induction therapy. Okay. Induction therapy regimen for any pre-BALL with pH positive. pH is Philadelphia chromosome positive. Then you have to start on tyrosine kinase inhibitor. You know the tyrosine kinase inhibitor, right? I don't need to tell you. You all know the tyrosine kinase inhibitors. Plus cyclophosphamide, vincristine, daunorubicin, dexamethasone, any of these drugs, cytarabine and methotrexate with asparginase and prednisolone. Any of this drug, you will make a combination of this. Depends upon the different patient and their comorbidities and their age. This regimen is called Berlin-Frankfurt Munster. Oh my God, somebody is honking. Okay. So this regimen is called Berlin-Frankfurt Munster regimen. Okay. Just remember the drugs. First line drugs are your TKI, tyrosine kinase inhibitors, cyclophosphamide, and any of these drugs with PEG asparginase or prednisolone. Next thing, you should know the adverse effect of all these drugs plus mechanism of action of all these drugs, which we covered in our pharmacology. And we are having a free session sometime later, just targeting all the monoclonal antibodies. Okay, some free session for the free group and some full extended session for the subscribed group. Okay, then if there is a Philadelphia chromosome negative B and TAL, this is for Philadelphia chromosome positive and negative B and TAL. In case of any negative Philadelphia chromosome, you will not go ahead and give a TKI because tyrosine kinase inhibitors will not work there. Okay, please don't ever mark TKI or a tyrosine kinase inhibitor in case of a Philadelphia negative ALL, B or TALL. Okay, this has been cleverly asked in last part 2 examination. They mentioned ALL and they mentioned Philadelphia chromosome negative, and many candidates, in spite of the fact, went ahead and they just marked TKI, and they all asked that question. Okay, in case of Philadelphia chromosome negative ALL, let it be B cell or T cell ALL. This is the standard regime. Just remember the very first line: daunorubicin, vincristine, prednisolone, and PEG asparginase. That's all. You don't need to know the entire thing. This is for a specialty certificate examination oncology level. Okay. Daunorubicin, vincristine, prednisolone, and PEG asparginase. This 4 is more than enough. Okay. This 4 is more than enough. Then if there is a high leukemic burden, this also has been asked in MRCP, high leukemic burden, and the WBC count is so high, more than 100,000 microliter. Okay. Then the regimen is cytarabine hydroxycarbamide with or without corticosteroid. Okay. Cytarabine hydroxycarbamide with or without corticosteroid. This is the regimen in case of a patients with a very high leukemic burden. Part 2 question. What you are seeing right in front of you is a part 2 question, and part 1 people, you should also be prepared for such questions, because there is a huge makeover for MRCP examination, as they are also in need of doctors for the next couple of years due to recent transmigration from a lot of people in UK to European countries and to Australia. Now they are mellowed down a bit with payment and everything. So it's a very high time you guys can study and go through. Okay. So these are the drugs you will give in case of a high leukemic burden. Once again, you should know what is a high leukemic burden. WBC more than 100,000 microliter. And the regimen is cytarabine hydroxysteroids. Then the second is consolidation therapy. Moderators. Okay, consolidation is achieved by the use of intense multi-agent therapy. There, lot of drugs are used, starting from your methotrexate, citrabine, mercaptopurine. They may not ask you, but just remember there is a second phase of treatment called consolidation therapy. Induction therapy regimen is must. You should know. High leukemic burden, what treatment you have to give, that you should. Then comes consolidation immunotherapy. What are the immunotherapies that can be used in ALL? This is very important. In CD20 positive patients, you can use rituximab. All right, you can use rituximab. And patient with BALL in first or second complete remission, you can use another drug called blinatumomab. It's targeting CD19 and CD3 T cell. This question hasn't been asked, but remember this drug. It's called blinatumomab. This is the drug. It targets CD19 and CD3. This is another drug. It's used in consolidation immunotherapy. Then comes maintenance therapy. Maintenance therapy, usually they will start a vincristine and prednisolone combined with mercaptopurine and weekly methotrexate. This goes up to 2 to 3 years. But even if you forget everything, just don't forget the drugs used in induction therapy, drugs used in high leukemic burden, and immunotherapy. Very, very important. 2 drugs are used, that is rituximab, and another one is blinatumomab. Right? Then CNS prophylaxis. Then most of this ALL, they have a high propensity to go and disturb the central nervous system by leukemic infiltration. So this is a need to give some prophylaxis. The best prophylaxis that is being used are intermittent intrathecal methotrexate alone or with intrathecal cytarabine and intrathecal hydrocortisone. This is called a triple intrathecal therapy. Please note it down. This is also an extremely, extremely important pointer for MCQ. In case of CNS prophylaxis in ALL, we give intrathecal methotrexate alone or with intrathecal cytarabine and hydrocortisone. This is called triple intrathecal therapy. All right. This is called your triple intrathecal therapy. Then poor prognosis. I'll just post the slides there. There is an update there. Can you guess what is it? Can anybody tell me what is it? Spot diagnosis. Any PACES people? Spot diagnosis. Please type your diagnosis. What this could be? In a CA patient, in a hematological CA patient. What is it? Come on. I want all of you to be interactive. Please don't be silent. Please type something. Tell me what is this. I believe all of you can see the screen. Good thinking, but Kaposi sarcoma is most common in HIV. Actually, it's most common in non-immunocompromised individual, especially of African American origin. Then comes HIV. No, that's not spider needle. Cutaneous T cell lymphoma. I mean, you're talking about Sézary syndrome. Oh, that's not this one. This is not Sézary. Anyone else? This is something called as leukemia cutis. This, okay, leukemia cutis, leukemic infiltration into the cells. It's called leukemia cutis. Cutaneous T cell lymphoma is slightly different. It's called Sézary syndrome. Okay, that we will see some other time. When we are dealing with dermatology, we will see that. Okay, this is called leukemia cutis in a leukemic patient. In any hematological malignancy can occur, especially in leukemia patients. All right. The next is AML. AML, the risk factors are same, and even the presentation are almost the same, except for the hematological parameters, which we will see. AML, you should know the very first thing you need to know is the types of AML. That is AML with minimal maturation, minimal differentiation, with or without maturation, acute basophilic leukemia, acute myelomonocytic leukemia, acute monocytic leukemia, acute erythroid leukemia, acute megakaryocytic leukemia. I'm not going to go in depth about translocations right now. Okay. Next symptoms, same, but here the mucosal bleeding, gingival hypertrophy, and bone pain are very common. Okay. Especially when you find something like a gingival hypertrophy, then make sure you are dealing with an AML compared to all the other leukemia, especially gingival hypertrophy and mucosal bleeding. That MCQ has been asked so many times in part 1. I hope all of you are aware of it. Okay. Mucosal bleeding and gingival hypertrophy with all the same other, like your ALL. In investigation, if you see the peripheral blood cells, you will find the presence of oil rods. Just remember the name, oil rods. And presence of hypergranular promyelocytes with bilobed nuclei. I'll show you a bilobed nuclei. These are called oil rods, especially acute promyelocytic leukemia. These are called oil rods. I hope all of you can see this. For two people, they will give you an image like this. They will give a history like somebody having a weight loss, or like, bleeding, or they may give, if you're lucky enough, they will give gum hypertrophy or bleeding through gums, or they may not give you, but they will put the slide. You have to see the slide. You have to know this. What is oil rods? For this, you have to see multiple slides so that in one glance, you will easily make it out. This is a bilobed nucleus again. See here. It's a bilobed nucleus. Again, here there is an oil rod. Okay. Especially in acute promyelocytic leukemia. This is a hypergranular promyelocyte with a bilobed nuclei and oil rods. Again, acute myeloid leukemia, okay, with delicate nuclear chromatin, and the nucleoli is very prominent, and there are some granules called fine azurophilic cytoplasmic granules. And find this fine azurophilic cytoplasmic granules. You can find over here. These are fine azurophilic cytoplasmic granules. If you find these terms, then you should be easily knowing that you are going towards AML. This is not ALL. This is AML. Once again, bilobed nucleus, oil rods, and azurophilic cytoplasmic. These are very important points. Okay. Then again, another picture for part 2 people. Okay. These are neoplastic promyelocytes. All right. And numerous azurophilic granules. Okay. Numerous azurophilic granules. And multiple oil rods, needle-shaped structure, oil rods. The picture I am posting is of good definition. I believe and I pray that your part 2 exam centers should have a good sense system, and they are sensible enough to post high definition pictures. Okay. These are multiple needle-shaped oil rods. Then in the bone marrow examination, what you will find? You will find blast cells, you will find oil rods. Okay. And you can find differentiation antigens like CD33 and CD34. The names and numbers are extremely important. CD33 and CD34, very important. Again, flow cytometry. Okay. CD33 and CD34 in case of a AML. So what is the treatment? Here treatment again goes in phases. The phase 1 is an induction therapy. Standard induction therapy is the backbone. Okay. Typically, the latest recommended guidelines is cytarabine for 7 days followed by anthracycline, either daunorubicin or adagrasib for 3 days, 7 plus 3 regimen. This is very important. Induction therapy is your cytarabine with any anthracycline like a daunorubicin or adagrasib. Okay. Next is your post-induction and consolidation therapy. Here again, a high dose cytarabine used alone or sometimes in combination with mitoxantrone, etoposide, or amsacrine. You should know again ADR and mechanism of action of all these drugs, which I am not going to cover here. Somebody wants to see azurophilic granules. Here are your azurophilic granules. This is a better definition picture for azurophilic granules. Can you see this, doctor? And here, can you see? And just see here, there will be a better. Here you can see azurophilic granules better. Yes. I'll try to pull up some pathology slides for you if you need more pictures. These are iron rods. Again, the granules are seen here. These are iron rods. Okay, hope you have seen. If you want, I'll post some better pictures in the group later. Okay. Now we are here. Now targeted therapies. Again, targeted therapy is very important for all the cancers, all the hematological malignancy. If there is a CD33 positive AML, okay, if there is a CD33 positive AML, the drug you will give is gemtuzumab. At least remember that gemtuzumab. CD33 gemtuzumab. If there is FLT3 mutation, the drug is midostaurin. These two drugs, just remember the names, that's enough. And what it targets. You don't need to do anything complex. What is the target? The name. And if there are any peculiar adverse effect, just remember. Peculiar adverse effect. This is how to study smartly. You need not study a bunch of theory. So many people are texting me asking what book I should buy. I should study Harrison's, to study this huge Oxford textbook of internal medicine or some Cecil and Goldman medicine. You don't need to study any such books. Just learn smart. This is what this is. This. Just one page, it will take hardly half a page. It will take if you take the entire essence of the slide, what I am teaching for 1-1 cancer. Just 2 pages enough. Take notes for this thing. Go through that. Work out MCQs. You will clear in no time. If you are going to sit and study and mug up unnecessary theory, you will end up really bad. That's about MRCP. Okay. So now comes, these are the 2 targeted therapies in AML. Then comes the third cancer, that is chronic lymphocytic leukemia. Remember, this is the most common leukemia in the Western world. This is an MCQ point. The first slide itself is an MCQ point. CLL is the most common leukemia in the Western world. Make it very, very clear. Next, the investigations. The risk factors are the same. The manifestation, clinical manifestations and the physical examinations are going to be the same. But the investigations matters a lot. Here, there will be elevated absolute lymphocytosis. And the blood film will show something called smudge or smear cells. This is a very, very, very important differentiating factor to differentiate it from other 3 malignancies. The smudge cells. This is a classical smudge cell. I hope all of you can see this. This is a classical smudge cell. I wanted to zoom it out and put, but if I zoom, the picture is getting pixelated, which I don't want to happen. This is a smudge cell. This is characteristic feature of a CLL. Okay. Then in flow cytometry, you will find B cell clonality, positive for B cell surface markers. This has been asked in MCQ. You have to remember 19, 25, 23, 10, 43, 200 and cyclin D1. This list you have to remember because this list has been asked multiple times and there is no excuse other than to read and remember this. Lymph node biopsy will also show the same markers. But in FISH, fluorescent inside hybrid test, here in FISH technique, you will find cytogenic abnormalities like deletion 13q, 11q, and 17p. You'll find deletion 13q, 11q, and 17p. These are the 3 things which again you have to remember. There is no excuse but to remember, just like you have to mug it up, these names. Okay. Now the treatment. Please remember, again this time part 2 they had asked. The technique has a slight difference, doctor. I'll post a picture, okay? The technique has a slight difference. I don't know the in-depth thing, what they exactly do, but I know the outcome only, okay? Flow cytometry and FISH are slightly different from each other. I'll explain how it is different from each other after just going through that, okay? Active surveillance, first thing. And first thing, remember, in any diagnosis of CLL, they will ask the management. This disaster happened in recent part 1 examination, not the part 1 examination. You are welcome, doctor. What has happened is, the question is very clear. That's CLL, okay? And the patient is asymptomatic. Only the blood finding shows it's a CLL. Maybe you see some smudge cells, okay? And flow cytometry shows marker of CD19, CD20. They asked, what is the next step in the management? Almost everyone I came across, they went and marked down some chemotherapy drugs. In CLL, it's not the case. That is why this slide is there for you. Any asymptomatic patient, please don't treat. You just need to do active surveillance. This slide is very important. Any asymptomatic patient, active surveillance. Nothing else you are giving. I can tell this 10 times also. If you want me to tell, please listen. Never ever mark a treatment in case of an asymptomatic patient. And what are the things you will do in active surveillance is full blood count with differential flow cytometry and routine physical examination. I don't think in the Asian side, the physical examination value is out, completely out. I'm surprised to see a cardiac. I wanted a patient for PACES examination. I wanted a double wall replacement guy to show another candidate who was preparing for PACES. So I asked a cardiologist. He's one of the big time cardiologists here. To my surprise, when I entered his cabin, I can't find a stethoscope around his neck, nowhere in his table. Trust me, nowhere in his table. I was totally taken aback. Then this guy was using a very small, ultra advanced device that acts as a stethoscope and acts as an echocardiograph. So he probe as well. The entire thing he can watch in his monitor. That's it. No more hearing murmurs, S1, S2, where it is radiating, what is the intensity of the murmur, what other added sounds are there. No, nothing. These are going to be absolute, I think, in the future. That's why whenever I see the term physical examination, it is completely going to go absolute in the near future. I think in 10, 15 years down the line, MRCP PACES examination, they will keep an echo machine for you. Please see the parasternal long axis view and tell what is the abnormality, or they will ask you to calculate ejection fraction. That's the way the things are heading into. But still, physical examination is the best bet for anything. Okay. So what is the indication for immediate treatment? So you don't treat anyone who is asymptomatic. All of you got it? And active surveillance includes three things: FBC, differential, flow cytometry, and routine physical examination. So when you will treat the patient immediately, there is a chance of any clinical trial. Progressive anemia and thrombocytopenia, any threat or end organ function. Symptomatic patients, any symptomatic, any painful lymphadenopathy, fever, okay, with or without infection, and drenching in nights. These are called your B symptoms. Okay, I have not included B symptoms because all of you know this: anorexia, weight loss, night sweats. There is no point in telling this again. Severe fatigue and any unintended weight loss, and rapidly progressive disease. Doubling time of lymphocytes in less than 6 months. This has been asked as an MCQ in MRCP on this pointer. Doubling of lymphocytes in less than 6 months. Okay, rapidly enlarging lymph nodes or liver or spleen, any bulky disease, spleen more than 6 centimeter, autoimmune hemolytic anemia. All these cases you have to start the treatment immediately, or in anyone who is already on an immunosuppressive therapy for something else, you have to start the treatment immediately. These are the indications to start the treatment immediately. All of you noted down. And don't treat anyone who is asymptomatic. That is the one point I want all of you to remember in CLL and smudge cells. Now the treatment is of two kinds. Okay, if there is deletion of 17p and there is a TP53 mutation, treatment differs. If it is present, if it is absent, treatment differs. If it is not there, okay, suppose deletion of 17p and TP53 is not there, or in the question if they didn't give you anything, the best and the first drug to start is with the BTK inhibitor with the CD20 monoclonal antibody. You know all the CD20 monoclonal antibody. BTK inhibitor, or you know, acalab, rutinib, and obinutuzumab. All these are your BTK inhibitors. Okay, I hope all of you know what is a BTK. What is a BTK? BTK means Bruton tyrosine kinase. All right, just remember this. That's more than enough. That's the first line. Now, if it is with the 17p TP53 mutation, again a BTK inhibitor, and again monoclonal antibody, then later things differs. Just remember this, it's more than enough for CLL. This is the first line now as per the latest guidelines. Okay. Okay, now comes to the blast malignancy here. Just we are going through the salient points. CML. CML is a malignant clonal disorder of a hematopoietic stem cells that results in marked myeloid hyperplasia of the bone marrow. Now comes disease progression. You should know this. It progresses through chronic phase, accelerated phase, and blast crisis phase. Okay, blast crisis phase. In the chronic phase, the first 5 to 6 years, patients will be asymptomatic. Then once the accelerated phase starts, there will be fatigue, tiredness, and you can find splenomegaly. And then goes to the blast crisis phase, where there is increased blast cells in the marrow, blood, and extramedullary disease. This is called a blast crisis phase. This is how the disease progresses. So coming to the investigation, typically same like full blood count, you will find anemia, you will find thrombocytopenia, and peripheral blood smear, you will find mature or maturing myeloid cells, including band forms, metamyelocytes, myelocytes, promyelocytes. Full lineage you will find. If you're finding this full lineage of metamyelocytes, myelocytes, promyelocytes, blast form, mature cell, maturing cell, matured cell, all these things, if you're finding all the lineage, then you are dealing with the CML. Okay, then you are dealing with the CML. And the specific investigation FISH will show T922 translocation. This we all know. This is CML peripheral blood smear. You can find granulocytic forms at various stages of differentiation. Okay, part 2 people, you should know how a smear with various stages of differentiation will look like. And part 1 people, you should be able to catch up the diagnosis if they put something like this. That in the investigation column, the table you can find in the peripheral blood smear, you find promyelocyte, myelocyte, metamyelocyte, and all the forms, various signs, various cells at various stages of maturation. Then you are dealing with the CML. Management, in the first line, we all know tyrosine kinase inhibitors like imatinib. Okay, imatinib. Then in accelerated phase, you can again start tyrosine kinase inhibitor, and another drug that has been approved by FDA recently is omacetaxin. There's another drug that has been approved by FDA for CML. Then blast phase. Okay, again tyrosine kinase inhibitor. If you know tyrosine kinase inhibitor, that is the only thing that has been used. One latest drug that is added is omacetaxin is added for CML. This is for the blast phase. That's about CML. This is another quick lecture for you from MedXM Expert. With this, I'm winding up, and I hope that benefited you. Thank you everyone for listening. Again, tomorrow I won't be available. Again, Saturday, we will be having a lecture on nematodes as requested. All right, nematodes as requested. Thank you so much for attending, and you are most welcome, guys. And please leave your valuable feedback in our free group or respective group where you came from. And please leave the topics which you find difficult for part 1, part 2 cases, even cases people. If you have difficulty seeing cases, if you have any issues any issues in understanding some topics, you have tough time understanding things, if you just attended an exam, you flunked, no problem. Please come to us. We are ready to help you out. Okay, and see you guys. Thank you so much. Bye-bye.